Welcome back, part 2 of my update on dysautonomia in long COVID. I'm Dr. Tim Robinson, formerly a family doctor for 30 years, now working in Long Covid Services for 5 years. I post on all the usual podcast channels and also YouTube. I hope you're finding them helpful. And if you do, please click subscribe. I want as many followers as possible, not for my own personal gain, but because I want this information to get out to you long COVID sufferers and to as many of you long COVID sufferers as possible. Because certainly here in the UK, a lot of the long COVID services are being withdrawn. And so I see this as a valuable resource, trusted valuable resource for those of you with long COVID. Of course, I always add my disclaimer, and that is any advice or treatment that I mention needs to be considered only after you've talked them through with your own GP family doctor. So there we are. So part 1, dysautonomia update, I talked about the symptoms, and then I also talked a lot about the causes, didn't I? So here we are in part 2. I'm going to talk about how we go about tackling long COVID dysautonomia. So before I get into it, I just wanted a quick recap. What is dysautonomia? Remember what I said? Basically, dysautonomia is an abbreviation of dysfunction of the autonomic nervous system. Autonomic, read automatic nervous system. So autonomic nervous system. Dysfunction of dysautonomia. You've got it. So what happens in dysautonomia? Basically, or what led to it. Remember I talked about the causes. It's a problem with the body system that should be working automatically, but it doesn't. Our autonomic nervous system takes control of those things like heart rate, pulse, blood pressure, balance, breathing, gut control, bowel and gut and bladder, and temperature control. That's what the autonomic nervous system does without us thinking. It happens automatically. Dysautonomia is when the autonomic nervous system goes wrong, dysfunctional. So what are we going to do about it if you have any of those symptoms that I listed? To do with the heart and the lungs and the abdomen and the bladder and the temperature. So what are you going to do about it? Basically, you know what you're going to do about it. You're going to go to your doctor. New symptom, off to the doctor for an explanation. Make sure that we're not COVID blind. Let's see what the doctor says. Hopefully we can get to a diagnosis and the doctor can treat accordingly. Which leads me into, what are the treatments? What are the treatments to consider in anyone who's got long COVID dysautonomia? First of all, I wanted to talk about the symptoms, the treatment of the specific symptoms. Like I said, there are so many different symptoms, and some people have more of such and such a symptom, and some people have less of such and such a symptom. So we can actually focus on all those symptoms. And as you know, that list is long. So let's just go through it nice and slowly, and I'll explain the different treatments for each of those different symptoms. So I started with the cardiovascular system. Okay, well, let's talk about the commonest presentation for cardiovascular problems in dysautonomia, POTS. Okay, the other, of course, is inappropriate sinus tachycardia. So listen to the POTS podcast if you want a little refresher on what POTS is, postural orthostatic tachycardia syndrome. So what are the treatments for that? Well, always, when possible, if possible, consider the non-drug treatments first. Always the simple stuff first. Okay, so the treatments we recommend, or strategies, let's call it strategies, are taking an extra teaspoon of salt in your diet. So a teaspoon of salt, 6 to 8 grams of salt on a teaspoon. Add it to your food, or mix it in with a glass of orange squash or what have you. Just get it down you. One proviso though, that obviously if you have high blood pressure or you have kidney problems, do not have that. Do not take that salt. But the majority of our patients are youngish and don't have blood pressure. And indeed, in dysautonomia, low blood pressure is commoner than high blood pressure. So bear that in mind. But, be careful. Obviously, so the doctor will have measured your blood pressure to exclude high blood pressure. The doctor will have sent blood for kidney function. Make sure that's all right as well. But yes, added salt. That's a treatment for dysautonomia. Also added fluids. So 2 to 3 litres of clear fluids extra over your normal sort of fluid intake. The reason behind both of those is to do with expanding the circulating blood volume. So therefore, if there's more blood in the circulation, there's going to be less likelihood of pooling of blood in the legs and the lower pelvis and the lower abdomen. Therefore, there's going to be better blood return to the heart and hence and also the brain, and therefore less likelihood of palpitations, in particular POTS, postural orthostatic tachycardia syndrome. So this is the non-pharmacological side. Then we do have bisoprolol, which is the first line treatment, which is a beta blocker. We have ivabradine, which is second line, probably prescribed by a cardiologist. Bisoprolol, safe as houses, as long as you don't have, really brittle asthma, and you don't have really low blood pressure. Bisoprolol is such a common drug. We use it. And has been in use. The beta blockers have been around for probably half a century, and so they're safe. But and the GPs are very familiar with prescribing this. I used to prescribe it all the time. It's for cardiac control, for things like atrial fibrillation, but it is very, very commonly prescribed. We feel confident in general practice, family medicine, to be able to prescribe this, and it works wonders for dampening down and extinguishing those palpitations. So those are the treatments for palpitations. Next on the list is blood pressure. Like I said, in dysautonomia, sometimes that can lead to something called orthostatic hypotension. So dropping of blood pressure when you stand up. Translated orthostatic hypotension. And there are a couple of drugs that can be used. Again, first line, second line. First line, fludrocortisone. Again, I remember prescribing this in general practice for those. They usually tended to be elderly gentlemen with drop of blood pressure when they stood up, postural hypotension. But it's very good for orthostatic hypotension in our dysautonomics. And, it's known as a mineralocorticoid. And, you've got to monitor the blood electrolytes, the salts in the blood. Yes, you've got to, but we're familiar with that. That's easy. But it is very good at preventing this drop in blood pressure. As I said, that's first line. Second line is midodrine, which is basically it tightens up, it's a vasoconstrictor of the blood vessels, so sends more blood up into the sort of the core body, up to the heart and also the head. So midodrine, but this is usually initiated by the cardiologists. So that's blood pressure problems in dysautonomia. Moving on from that to breathing. Okay, so breathlessness. Some, patients tell us that they feel breathless, or indeed when they're walking upstairs, they sort of get halfway up the flight of stairs and have to stop, catch their breath. Obviously, this is something that has to be looked into very carefully with your own GP. And, it's got to look for all the other causes, like, is it low grade asthma, newly presenting asthma, or is it a COPD being sort of unveiled? Is it sort of a problem with the control of the breathing rate because of the effects of the COVID on the brainstem? So there are lots of underlying pathologies which we have to be thinking about when we're considering someone with breathlessness. However, when all those pathologies are excluded, common presenting problem in our long COVID patients is something called breathing pattern disorder. Okay, so if you like, rapid, shallow breathing sort of makes you feel a bit short of breath. And so to be able to retrain your breathing and get back into that normal, because you get into a bit of a bad habit with your breathing, right? Sure. And panting almost like hyperventilation. So you get into that bad habit of a sort of dysfunctional breathing. So learning breath control, and you ought to listen to my podcast on breathlessness. There are various strategies, tips and tricks which we train, and the respiratory physiotherapists are expert at training the patients to be able to breathe more controlledly and to take control of your breathing and relearn correct, proper breathing, diaphragmatic or belly breathing as we call it. So that's breathing. Next on the list is gut problems. Okay, well, one of the commonest problems, and I have mentioned this before, is IBS, irritable bowel syndrome type symptoms. And what I mean by this is bloating, excess gas, gurgling, and an alternating bowel pattern. So going from sort of once a day, opening the bowel once a day with a full motion, to going 3, 4, 5 times a day with a semi-full motion, and then back to once a day full motion. So you see, it's variable bowel habit. So typical of IBS, but it's generated by the underlying processes of dysautonomia. There are treatments for this. Mebeverine, Colofac, mebeverine really, 135 milligrams 3 times a day, is very good as a sort of antispasmodic. Then there's peppermint oil, and then there's loperamide, which works differently. Loperamide works differently, and it's used often in patients with inflammatory bowel disease who are typically opening their bowels sort of 4 or 5 times a day. So any of those drugs are at the fingertips of the GP. GPs are very familiar with prescribing those to address those typical IBS type symptoms. One thing to say though, and I did mention this earlier, and that is, it is, the red flags. Obviously, any change in bowel habit has to be taken very seriously. It is a red flag. Change in bowel habit out of the blue, going from, like I said, once a day to, 4, 5, 6 times a day, or once a day regularly to 4 or 5 days without, and then going to open the bowel. Change in bowel habit has to be taken seriously, because we want to make sure we're not overlooking something more serious. And of course, I'm talking about the big C, cancer, that is causing this blockage, obstruction. So, obviously, take your symptoms to the doctor, to your GP, and explain them. And the doctor will probably, if it's completely unexplained, out of the blue, never had it before, will probably want to send you off to have what's known as a colonoscopy. So a scope up the tail end to make sure that there's nothing sinister, nasty lurking in the colon. So that's the gut side of things, halfway through. Next, going up to the head. Headaches and migraine. Like I said, there are some patients who've never had a headache in their life, and then ever since they've had COVID, now long COVID, are troubled with daily headaches. They've never had it before. Likewise, migraines. Migraines have been nicely controlled or just happening infrequently before COVID, and now they're happening all the time, and they are not responding to the usual treatments. So what do we do about it? It all comes down to how often you're having these headaches or these migraines. If they're happening very frequently, so daily or even anything up to twice a week, you're having these terrible headaches that last a day or two, 3 days, whatever. You need to have medication that prevents them. You need preventative treatment, i.e. something to take on a daily basis. So not just, when occasionally I have a headache. What do? I take a paracetamol. Just, to get rid of it. Some people with migraine, what do? They just take, if it's once in a while or, it's migraine associated with the onset of a menstrual cycle period, then, that lady will take an imigran, sumatriptan, to actually, address the problem while it's there. But because she's not going to have another migraine until 4 weeks later, next period, then there's no point in having preventative treatment over that next 4 weeks when you weren't going to have a migraine anyway. So it all comes down to the frequency, and you should be on preventative treatment if you're having your headaches on a regular basis more than twice a week, and likewise migraines. And there are, there are treatments to prevent this. We usually use, in general practice, we usually start with amitriptyline, 10 milligrams at night. Again, this drug's been around since like the 50s, so at least half a century. And so, it is safe. 10 milligrams at night, and, you can go up to 50 milligrams, but, 30, 40, 50 milligrams at night, then makes you feel a bit sort of dopey and hungover the next day. So maybe 10, maybe 20 milligrams at night will bring the migraines under control. And you could use that for regular headaches as well. If you can't tolerate amitriptyline, or it's ineffective, or you get side effects, then there are some alternatives. That's one drug called topiramate, another called valproate, another called candesartan. These are all accepted, NICE guidelines approved. So NICE stands for National Institute of Clinical and Health Excellence. These are all NICE guideline approved and worth trying. Certainly worth trying. If you don't like drugs, pharmaceuticals, and a lot of people don't these days, you could try other evidence-based supplements. Evidence-based, he says, yes. So the studies that are published in respectable journals that have demonstrated effectiveness. So the first is vitamin B2, so riboflavin. Start with 100 milligrams. You could go up to 400 milligrams as a once-a-day dose. Like I said, this evidence-based medicine has backed up this as a certainly effective, not in everyone, but certainly worth trying. Another is magnesium. So magnesium 2 to 400 milligrams. Again, once a day. So be careful about magnesium though. There are lots of different magnesium salts. The really cheap ones, magnesium hydroxide, are not going to have any effect. Plus also they'll give you diarrhea. So magnesium citrate or magnesium glycinate. Try those. Not at the same time as the riboflavin, one at a time. If riboflavin is not effective, then try the magnesium instead. So one thing at a time. That's the advice I normally give anyway. And that is, experiment with one thing at a time. And if it works, great. And, after taking it for a month, you say to yourself, am I better, worse, or exactly the same? If I'm better, bingo, fantastic. Keep going with that particular supplement. If you're worse, obviously you're going to want to stop it because you're feeling worse. Or if you're exactly the same, actually it's not made any difference, you're not going to want to take it, are you? So there we are. There's another one is coenzyme Q10, 100 milligrams. Again, there is evidence, published evidence in journals to say that that is helpful for patients with migraine. So that's migraine and headaches. The next dysautonomic symptom is nausea. Again, we've had a number of patients coming through our services who say, I've got this awful sick feeling all the time. I feel permanently like I'm going to be sick, nauseated. Again, this is, in a way, quite easy for a GP to tackle. And there are a couple of, widely used, lots of experience drugs to tackle nausea. Cyclizine would be my first port of call, 50 milligrams. It's something that we've used forever. Anaesthetists use it all the time. And Dysautonomia is the next one we tend to use for this sort of nausea of sort of central origin. So, i.e. central, when I say central, I mean from the brainstem. There's a part of the brainstem called the chemoreceptor trigger zone, which triggers nausea. So either of those are acceptable. And as I say, all GPs prescribe them all the time. Balance problems. Remember, balance. There's, again, I've got a whole podcast and YouTube on balance, dizziness. Dizziness is called the Dizziness podcast. But when we're focusing on the dysautonomic causes for this, and more specifically the vertigo type of horrible room spinning type of roller coaster type of vertigo, prochlorperazine, good old fashioned Stemetil, is excellent, either as a tablet, 5 milligrams 3 times a day, or Bucostem, which is the dissolvable sublingual under the upper lip, under the lower lip, to get straight into the circulation. And obviously the sense behind that is that obviously balance problems can be, you can have nausea and vomiting with balance problems. And so if you vomit up your Stemetil 5 milligrams tablet, then that defeats the object somewhat. It's better to have a dissolvable one under the upper lip, lower lip. So that's prochlorperazine, Stemetil, or Bucostem, the dissolvable. Next symptom in dysautonomia, sleep. Sleep problems. Yes, such a familiar symptom in our long COVID patients. It's one of the top 10. So basically, what do we do about that? Okay, well, you could sort of go down the pharmacological route, and so chlorphenamine, so Piriton, 4 milligrams at night, so an hour before going to sleep. Again, it's been around for like donkey's years, for half century at least. Safe as houses. You can buy it over the counter, no problems. Worth trying, first of all. It is an antihistamine, yes. We don't use it for hay fever and that sort of thing now because it causes sedation. So we use it for that side effect, and that is the sedation element to it, i.e. to help your sleep. Doctors now, obviously we shy away from the Z drugs, Zopiclone, Zolpidem, these minor tranquilizers, because they're addictive and they become dependent on them. And so we tend to use amitriptyline. Yes, we've come across amitriptyline already, haven't we, for those headache migraine prevention. And same dose, 10 milligrams, so an hour before bedtime, to help enhance nodding off, sleep enhancing. So amitriptyline, again, safe as houses. One little aside, that if your doctor prescribes it, hopefully the doctor will explain, okay, don't get frightened, because if you look at the small print, it says amitriptyline, tricyclic antidepressant. And then you're left thinking, he thinks I'm depressed. actually, you're not depressed. Yes, it was the first antidepressant that was launched way back in the 50s. Probably 50s. But none of us use it any longer because we have got, we've come a long way. We've got much better antidepressants that are not sedating. They don't have the side effects, and they're more effective. So the SSRIs, the SNRIs, are what we prescribe for depression these days. So, like I said, if you look at the small print and it says antidepressant, he thinks I'm depressed, don't think that. She is prescribing for that sleep-enhancing property. If you want to go non-pharmacological for your sleep problem, there's, again, some evidence-based supplements that you can take. So, again, magnesium. Well, we've met magnesium already as our headache migraine. So it's like I'm repeating myself. Yes, it has sleep-enhancing properties. Same dose as before, sort of basically 200 to 400 milligrams at bedtime, or an hour before, preferably. And then finally, melatonin, slow release, 2 milligrams. You can buy this online. Make sure it's a reputable retailer, of course. But 2 milligrams as a drug is a form called circadian, which is a slow release melatonin. And that is very effective. You can get it on prescription, but you have to be 55 and above and only for a short period of time, or for jet lag, but again, a very short period of time. The thought behind it is that it is a synthetic form of our own naturally occurring melatonin released from deep inside our brain, from the pineal gland inside our brain, which is our natural sleep-enhancing hormone. And so that's its property. So the thought is, the logic behind having it in synthetic form is that you're topping up what you're already naturally secreting from that pineal gland. So lots of suggestions there. Sleep. And then finally, the neuropathic pain. Remember what I said in dysautonomia, a lot of patients are pain hypersensitive. The slightest knock on the edge of the table, will be felt like severe pain. For some reason, the pain reading process within the brainstem has been scrambled and is misfiring, and so you're getting overreaction to pain, and sometimes leading to something called central sensitization, when you're actually experiencing pain with painless stimuli. There are a couple of treatments for this. One is amitriptyline. Yes, again, we're back to amitriptyline, the third time I've mentioned it. So that is, in a way, again, something in general practice, GP land, that's what we prescribe quite frequently when we diagnose neuropathic pain. There's another drug called duloxetine, which again is a separate group of drugs. It's from an SNRI group of drugs. Again, it's an antidepressant, but that's not why I'm suggesting that it should be used here. It's used here because it has neuropathic and it's proven neuropathic effects, neuropathic inhibiting effects. So there we are. That's the list, and it is a long list. But those are all symptoms. Those are all symptoms of dysautonomia. Those are all symptoms that there are treatments for. So take your symptom along to the doctor, and these are the treatments that we in general practice know about and can address those symptoms. Don't just live with those symptoms. These are symptoms that we can help you with. So that's I've covered dysautonomia symptoms. What about dysautonomia, the underlying causes? Okay. Well, I've talked about previously mast cell activation. What we found is that those patients with dysautonomia, they also have, there's a crossover with this condition called mast cell activation syndrome. Quick resume on mast cell activation. Basically, mast cells are part of the innate immune system, that first line defense of your immune system that kicks off when it meets a virus, a bacteria, a toxin, a foreign protein that it doesn't recognize. It activates this mast cell. The mast cells, they're in all the tissues in the body, but mostly in the lining of the gut, the lining of the respiratory system, and also on the skin. Unfortunately, part of the excessive inflammatory process in long COVID is activation of these mast cells, and they release their inflammatory components, their pro-inflammatory components, one of which is histamine. As I say, mast cell activation, there's a crossover, and they're often there present in tandem, if you like. And note what I said. The mast cells, when they're activated, they release their mediators, their inflammatory mediators, but the mediator that's there in each of those mast cells to the greatest concentration is histamine. So therefore, it makes perfect sense. You want to have an antihistamine. So a histamine receptor blocker. And there are two types. There's H1, histamine 1 blocker, and there's H2 blockers. Okay, so H1 blocker, cetirizine, loratadine, fexofenadine. These are second generation antihistamines, which we are all familiar with using in general practice. And, you can buy these over the counter after all. Don't just do that though. Take your symptom to the doctor. Check that you know what you're dealing with. Let's get a diagnosis first. So that's H1 blockers. H2 blockers. The H2 blocker, there's a class of drugs that first of all sunmetidine, then it was ranitidine, and now it is famotidine. So these have been around for 30, 40 years now, this group of drugs, H2 blockers, which are anti-acid blockers. Okay, so they're used for indigestion, they're used for heartburn, they're used for gastric ulcer, duodenal ulcer. But they are an H2 blocker. So mast cells have H1 receptors on them as well as H2 receptors. So to be more effective in treating mast cell activation, you really want to be able to block both H1 and H2. And that's why in mast cell activation, we treat with both of these, H1 and H2, in combination. So, for example, cetirizine, 10 milligrams once or twice daily, famotidine, 20 milligrams once or twice daily. Start with the lowest dose always, but, get the guidance from your GP. So, if you can help with the mast cell activation, you theoretically can help with your dysautonomia, dampening it down. Next, with dysautonomia, I've put in something more controversial, and that is vagal nerve stimulation. So the vagus nerve is the nerve that the parasympathetic, start again, go back to the autonomic nervous system. Remember I said it's the sympathetic nervous system, the parasympathetic nervous system. So the vagal nerve is the nerve that feeds responsible for the activity of the parasympathetic nervous system, the rest and digest nervous system. Automatic, again, autonomic, yeah. Now, the vagus nerve is basically 70 to 80% sensory. It takes in sensations from the peripheries, and it's reading. It's reading. It's our thermostat, and it's our pain sensor, and our smell sensor, etc., etc., and anything to do with blood gas sensors and our blood pressure sensors. So there are sensors all around, and they are firing off, and then they send their impulses up the vagus nerve to the brain. Now, if there is dysautonomia, there's imbalance between the autonomic and the parasympathetic nervous system, and in dysautonomia, it's mostly excessive sympathetic nervous system and poor parasympathetic. If we can bump up the parasympathetic function, theoretically, we can dampen down the sympathetic response, and hence address the dysautonomia. So people can go and how are we going to stimulate the vagus nerve? Well, there are, again, like I said, this is quite controversial, but if it works in you, you'd probably want to carry on doing it. Okay, so basically you can stimulate your vagus nerve either in the neck. There's a sort of probe that you can place over where the vagus nerve comes up, which is basically where the carotid artery, you can feel your pulsation there. That's one place you can access the vagus nerve. The other is, believe it or not, in the ear, the tragus, this sort of floppy, cartilagey, squashy bit here in front of the ear hole. There's a branch of the vagus nerve that, for some reason, feeds that takes its origin from there and then goes into the brain. So if that area can be stimulated, and you can go online and see these vagal nerve stimulators. So you may have seen these people where they're attaching these little electrode-y probe on that part of the ear that stimulates the vagus nerve. That can dampen down the sympathetic nervous system because the parasympathetic nervous system has been bumped up. This is what you want. I talked, I think, in the POTS the POTS podcast about breath control and the importance of using breathing as a way of controlling your parasympathetic nervous system, or more broadly, your sympathetic nervous system. Control breathing, belly breathing, diaphragmatic breathing can lead to dampening down. Some people call it parasympathetic breathing. Okay, so deep, controlled belly breathing, diaphragmatic breathing, as you breathe in, pushing your stomach out to maximize the expansion of your lungs. That brings about lowering of the pulse. Okay, and that happens through control via the autonomic nervous system. So if you can dampen down your dysautonomia, tachycardia by breath control, that's a good thing. So think about that. Along with all that, obviously, we don't, we think about, optimal health, your diet. I've said this all starts with inflammation, haven't I? And damage. And so we want to repair those damaged tissues. We can, with a sensible mixed balanced diet, a mixed balanced diet will provide you with all those building blocks for repair, those minerals and those vitamins and those probiotics and prebiotic fiber, which is going to nourish your gut microbiota, which is really important. And again, remember the vagus nerve, the parasympathetic, it takes its origin from all the organs in the body, basically, as well as the skin and the peripheries. But it takes many of its origins from the gut. And so your friendly bacteria, it's really important to nourish the friendly bacteria. We don't want what's known as dysbiosis. We want, basically a eubiosis, EU biosis, so friendly microbiota. Other treatments for dysautonomia, obviously, when I'm thinking of sleep, and I've talked about the melatonin, I've talked about, magnesium and pyriton and amitriptyline. Don't forget, simple stuff like, blackout curtains or eye visors. So it's dark, earplugs, to block out all noises, etc. We want to, use our sort of general approach, our holistic view. So there we are. That is dysautonomia. That's part 2 of my update on dysautonomia. Just to sort of basically skip through by way of a bit of a summary, remember safety first, new problem, off to your doctor, let's get a diagnosis, let's not be COVID blind. I talked about the causes, really important for you to have a grasp of that, for your own validation, for your own acceptance, peace of mind. I've talked about the treatments, and remember I broke it down to 2 really. Treatments of the specific symptoms. I went through palpitations, I went through gut problems, the irritable bowel type symptoms, that I went through headaches, etc. The symptoms of dysautonomia and what you can do about it. But I also talked about the underlying causes, and you need to address mast cell activation. Absolutely. But as I've said, let's take the overview picture in managing long COVID. We've got to think about, stress, and think about mindfulness, think about yoga. I've talked about diet. Think about your fatigue management, remembering the 3 Ps, the planning, the prioritizing, and the pacing. And remember, like I've said each time I say this, and that is, it takes time. It is long COVID for a reason. It takes a long time for natural healing, rebalancing, etc. to take place. So there we are. That's my update on dysautonomia in long COVID. Again, like as always, there's a lot of information there, and but that's the nature of the beast, nature of long COVID. It is a complex, complicated, multi-symptom, multi-series system, and multi-causal problem, which, is just, for so many people, just not fun. I hope you found it helpful. Like I said at the start, this is for you, for your long COVID sufferers. And, basically, if you find it helpful, anyone else who has long COVID, just spread the word, share these posts with them. Let's get this information out there, especially as we know, there's less and less resources, trusted resources for you sufferers of long COVID. So there we go. That's my update. So in the meantime, I wish you well, and wish you well in your long COVID recovery. So all the very best. Cheerio now. Bye-bye.